Hey, tribe, what's going on? Welcome to another episode of In Touch with Terri. We have something that might be a little spicy for you guys today. I'm thinking it might cause a little controversy, but from the most healthiest, productive, and much needed way. I have a very good friend of mine with me today who's got a sick bit of credentials that we'll get into a minute. But Tom Terranova with Quad A, the CEO of Quad A. Tom, welcome.
Thank you. Thanks for having me, Terri.
You are so welcome. All right, guys. The intention for this podcast, the title of this podcast is Accreditation in Action, Raising the Bar in Aesthetics. I want you to sit with that for 1 second. And maybe many of you are like, what the hell is she going to get into? Look, you guys know the aesthetic industry is booming. I mean, we are experiencing explosive growth. But that growth has far outpaced the regulations, especially in the non surgical med spa space. So while surgical facilities have long had structured accreditation systems, the most medical spas today operate candidly without any formal oversight. So, what does it look like to raise the bar and create a legitimate global framework for safety, consistency, and excellence? And I hope many of you guys are hell yes, we've been waiting for this. So, again, today, really excited, a dear friend, Tom Terranova. He is the CEO of Quad A. He's a globally recognized, it's accredited body known for its commitment to surgical safety. And now Quad A is literally the driving force behind the new accreditation initiative for non-surgical medical aesthetic practices, of which I am really honored to be part of that task force. So let me just share with you a little bit about Tom's background and why you're going to really want to tune in, take notes, and listen perhaps once or twice, and definitely share this with your colleagues. Tom serves again as the CEO of Quad A, where he oversees the organization's strategic direction, financial health, and resource alignment. Tom is also an attorney by training who previously advised multinational corporations using data analytics and has also practiced international mergers and acquisitions at one of the most world's largest law firms. So now Tom is channeling this experience and expertise into, candidly, what I think is one of the most meaningful leadership roles in his career and in the medical aesthetic space, helping to ensure that patient safety, quality standards are upheld both in surgical and the non-surgical medical aesthetic practices with far greater accountability. So again, Tom, thank you so much. This is a long overdue podcast. We've been at this for, God, how long has this task force been even going on? I feel like a year now.
Just past a year. Yeah, just a little
Yeah.
over a year now.
Um, so Tom, before we just dive right in, can you expand a little bit about your background and how long you've had Quad A and really what is it so people understand the validity and the seriousness of what you do and why it's important?
Yeah, absolutely. So once again, thank you. And I think this is a much overdue conversation, a much needed conversation in the aesthetic space. And I think, as you said, there's going to be a portion of people listening that think, hell yes, it's time we've had this conversation. There might be a portion of them that are scared. I'm here as sort of a champion and standard bearer for safety to say, if you're scared, don't be. If you're a well-intentioned practitioner, whatever we're talking about, all of the details that we get into and the details that will come in the future are nothing to be afraid of. The only people that should be afraid are the people who don't want to do things right. That's what I always say. Like it's a choice to do things the right way. It's a choice to do it in a way that's safe. And so for those of you listening who think that there might be something big and scary coming down the pipe, I don't think that's the case. I've been wrong before, but that's my sentiment. To your question about Quad A, where we come from and what brings kind of the validity of what we do, Quad A dates back to 1980. So it's 45 years old this year. It started really with plastics. So in that respect, some of the folks that are listening that are in the aesthetic space might be familiar with us from the surgery center side, from their previous careers, from their social circles. But really, as it was explained to me by Dr. Harlan Pollock, who's a way past president of ours, when plastic surgery was really migrating out of the hospital and into the office in the late 70s, it was, we'll say, controversial. But the way he put it to me, it was borderline malpractice, and they were terrified about getting caught out doing something wrong, about being accused of putting patients in harm's way for their own benefit. And so ASPS put together this task force in the late 70s to really figure out what was going on in the world. And that task force really said, we need an independent, impartial, arm's length third party to assess us for quality and safety, and just to convince and to build confidence in regulators, legislators, the public, and other practitioners that we're doing everything right, that we are really crossing the T's and dotting the I's. And so from that, actually, Quad A was born. So we started out simply as a group to provide impartial accreditation, inspection, and correction of mistakes or deficiencies or weaknesses in plastic surgery facilities. And that was, again, in the late 70s and officially incorporating it in 1980. And essentially, Quad A did just that, where like the A students, the cream of the crop, voluntarily chose to become accredited all the way through like 1997. And then in 1997, 1998, a couple of watershed moments happened. First, California became the first state to require accreditation for every office setting, no matter what the specialty was, as long as you were using sedation or higher. At the same time, both of the American Plastic Surgery Societies decided to mandate accreditation to say the specialty of plastic surgery is going to police itself, and essentially, if anyone wants to be a member of these societies, they have to become accredited or risk their membership. And so those kind of two big moments, one, pushed all of the plastic surgeons, formerly trained plastic surgeons, into accreditation, and California's rules started to diversify the folks that were coming to us. The big change there is that, not only the cream of the crop were doing this now, and it's now some folks that had to be pushed were doing this. And that's where we actually start to see an increase in what I think is our positive effect. I mean, our mission is patient safety. The clinics are paying for the services that we're providing, but really it's for the benefit of the patient. And so as we went through this dynamic, you start to see people who didn't necessarily want to go out on a limb and say, come and assess me and check me out and show how good I am. Now it was maybe your B students, maybe even some C students, maybe even some students that were on the border of failing that were coming and getting accredited. And so that inspection process took on a lot more importance, because now we're helping correct big gaps in safety and really, really improving patient safety across the board. And so those were big watershed moments. We actually began a Medicare approved program at the same time, 1998. It was our ambulatory surgery centers programs. And so from there, the snowball started there. So California, New York, Florida, a lot of big populous states started to require accreditation. Multi-specialties started to come into our group, and even multiple provider types, meaning in Medicare, for example, we also accredit physical therapy and occupational therapy and speech pathology, as well as rural health clinics, which really serve at-risk communities in the rural part of the country. And so that's a very long-winded way of saying we kind of grew out of this very specialized kernel in 1980 to being approved by Medicare federally in 3 different programs and by every one of the states that regulates office surgery across the country. And now we've worked at one time or another in 22 countries, but right now we're active in 15 countries, really at the forefront of making sure that patients are treated in the safest possible way.
Thank you. I mean, God, you shed a lot of light and insight for me personally, and I've known you for a long time, so I think the history of Quad A and the story, I think, is very relevant. So, our agenda today is really thinking about strategy, standards, and the road ahead for this industry. And we both talk at almost every single society. I know what's happening. I know the segment that just got released about a month ago. There's not a day goes by, there's something not in the news about what's happening. So I really want to impress upon the tribe listening that if you're new to me, thank you for listening and joining. And if you are my ride or die and you follow me for a long time, Tom did say something I think is important, like, don't be scared if you're feeling scared. This isn't intended for that reason. It is intended to bring awareness, education, and light to the fact that what he just said, patient safety is the number one thing that we do and have to pay attention to that. So, Tom, first question, what was the original concern that led Quad A to begin developing the accreditation program specifically in this non-surgical med spa space?
Sure. So if we jump in the time machine, I can tell you in about 2010, maybe even 2011, someone contacted the office. So I've been with Quad A since 2009, so I can jump in the time machine a little bit. So if we go back to then, somebody reached out and said, essentially, I think it was in California. They said, you need more certifications to do nails or makeup than you do to provide these injectable services.
Wow.
There really needs to be something done. And it was a really interesting call to happen, nearly, over a decade ago now.
Yeah.
And at the time, I think the organization wasn't ready to take that on. But as you've said quite right, the growth has been explosive. And I would say that it's not just outpacing legislation. I think the more concerning thing is that often the growth is outpacing common sense, right? You know it. Everybody in the industry knows it. Even if you are the most conscientious practitioner in the world, you can point to probably a half a dozen locations in your immediate vicinity that are doing things that are abhorrent and unconscionable. And they might be doing it through ignorance. They might be doing it through sort of being undermined. Maybe they're over leveraged. Maybe they have some other exposures that they're just trying to dig their way out of. Or maybe they really are bad actors. But whatever it is, the industry has exploded so quickly that really it's not just legislation that can't keep up. It's just practice, right? That can't keep up. So we've all seen this and we all know it's happening and we've all kind of watched it. And the truth is that there's great spas, med spas, there's great non-surgical aesthetic spaces, and there's places that are frankly terrifying. Yeah. And the point is that variability is the concern. So you asked for the original kind of the origin story. And I would say what's interesting for Quad A is everything started, back in the day from one specialty and sort of organically evolved into multi-state, multi-specialty, multinational. Well, what's interesting with this space is it was the first program that came kind of galvanized at the same time from three separate directions. So some people who may follow us, who may follow our podcast, who may follow our newsletter, who may be accredited, might have seen us promoting a lot of research that we did with a bunch of folks at University College London in the UK. Basically there, the UK government has identified same types of spaces, they don't call them med spas, but non-surgical aesthetics, as being a prime concern for them. The professionals who are providing the care, where the drugs are coming from, how are the agents and all the other chemicals that they're using, how they're procuring them, and then the facilities. So we worked with these researchers and found something like 80% of the providers are breaking at least one law, and there's only 2 laws on the books. Wow. So imagine how many laws they'd be breaking if it was actually comprehensive laws. Wow. And so that was sort of a UK thrust. At the same time, we're in pretty heavily, we're kind of the leading accrediting organization for outpatient surgery and for clinics in the UAE, in Dubai. That was a law that was passed in 2019, and they approved us, and we have since become the accreditor of about 70% of the facilities in Dubai. At the same time, there's only 50 or 60 surgery centers in Dubai, but there's about 2,000 non-surgical facilities.
Wow.
So
Incredible.
when you're talking about the size of a facility, I don't know if anybody's been there, but you can kind of drive from one emirate to the next through Dubai, which is one of the larger ones, in maybe an hour and a half, 2 hours. There's 2,000 clinics in that space that are not classified as surgery. So there's this impetus from the government in UAE to also get their handle on that too, because a lot of the same patient risks that we see in a surgical facility can exist in a non-surgical facility. And then obviously in the United States, I mean, you and I go to the ABAM meeting and several other meetings, and I believe it was there that one of the consultants got up, and I was kind of a bit more on the financial side, and spoke to the fact that this industry right now is only about 10% of the way saturated in the United States. So if you think that the amount of facilities that we see today is the amount we'll see in 36 months, it's completely the other way around. I mean, the growth will continue to be explosive. So in the US, we've seen the growth happening, and we see the investment, we see private equity coming in. And, in speaking to consultants and to people who work in the space, like you, like some of your colleagues, all of them are saying, well, our really responsible practitioners are clamoring for some sort of standardization. They're clamoring for something to say, you need to come to me and not the place up the street because we don't know what they're doing. And that's really very similar to what happened with plastic surgery back in the 80s. I mean, the big similarity here is this is a commoditized, financially kind of cash-based business, which is very different than other parts of healthcare where it's just like, who's my insurer going to cover, right? So now the onus is on the patient, and the patient is sort of pushing the agenda and saying, are you going to do the service for me or not? Are you going to do it when I want it? Are you going to do it, when I for the amount of money I want to pay? And all this stuff at the same time is leading them to kind of stop seeing it as healthcare. So I think all of those dynamics from the UK, from the UAE, from the US, and frankly, the researchers canvassed like 13 or 14 other countries, and it's the same story in every country. So this was really the push to say, look, this is something that needs to go out because it is a global phenomenon, it's a global problem. The world's only getting smaller and more connected, and this dynamic is repeating in every market in the world.
God, did you guys pack all that in? That was a lot. And this is so incredible. I'm sure we could literally talk for hours. So let's kind of get into some of the safety gaps. Talking about the continued growth and only 10% consolidation, and everybody and their Tom, Dick, and Harry, right, brother is opening up a place, right,
Yep.
wrong, indifferent, good or bad. It is what it is. I say it often on stage. This industry is a commodity, highly competitive. And when I teach what I teach as a business consultant or sales training, I'm like, you better do it right. Knowing data might be one thing, but if your team doesn't know how and why to do it, you got bigger issues. It's not about the next laser, the next marketing company, your beautiful space. I mean, that's kind of all nice to have, but not if the infrastructure and what we're talking about, this legal and compliance and safety is not, in place. So given this explosive growth that's going to remain, what safety gaps and risks have you seen that have stood out the most to you and your team?
Sure. So if I go back to the folks at UCL, at University College London, who we worked with, one of them is a physician by the name of David Zagarin, and their team came up with the sort of the 5 Ps protocol, and it's sort of the patient, the place, the practitioner, and the procedure, and the product. So I think product is huge, obviously, right? So product is a big one. And again, with supply chain the way it is, with connectivity the way it is, with people being able to order whatever they want from wherever they want, that's a huge concern. And I think I actually just saw a story maybe 2-3 days ago about somebody in a spa who got in trouble for buying from God knows where.
No, I heard some Alibaba. Like
Yeah, I think that's the
Alibaba,
one. Yeah,
yes.
they bought that out. Yeah. So that's a huge gap, obviously. The other gap, and I don't want to come across as derogatory towards your listeners or the industry, because I don't mean that to come this way, because again, it's so varied that there's the cream of the crop and then there's the stuff at the bottom of the cup, right? And I can tell you 2 years ago, I was at a meeting for the American Association of State Dental Boards, because dental boards, I don't know how many of your listeners are aware of this, there's dental spas too, right? And we're talking about injectables, facial injectables and things like that. Basically throughout the face, kind of down to the clavicle is kind of what the dividing line that they all talked about. Basically anything that would affect the smile. But these 3-day meeting of all of the dental boards, and I heard someone say, in my state, you could have a bridge person doing injectables by the afternoon. So you could pick someone up under the bridge in the morning, and by noon they could be injecting. And so the training, obviously everybody I talk to is highly concerned with the training. So the product, the training. The part that I think I get a little bit more passionate about, and it's probably because of Quad A's background, is sort of the other medical stuff around it. Like, you could train somebody to be a fantastic injector, but what's their kind of baseline medical knowledge? What's their knowledge of infection control practices? How is the sterile supplies? Because you still got sterile supplies. And spoiler alert, when we talk about surgery centers, the biggest weakness, one of the biggest points of deficiency, one of the biggest areas of concern we have when we have an adverse event, we go in and investigate it, it's always in the sterile supplies, or the lion's share of them originate in the sterile supplies and how those are maintained. And those are in surgery centers. So now when we take a step out to the med spas, that kind of background, sort of the back office tasks, not necessarily administrative, but the support system that's there is really concerning. And then especially when I talk to doctors who are medical directors at spas, or who have concerns, or maybe they own one, whatever it is, it's often the emergency response, right? So if you're a great injector, it could happen. Something could go wrong. What's the response, right? What's the big response? So I think if I were going to kind of put things in 4 big buckets, I think that those would be the ones.
Yeah. Well, God, it's even interesting. Even interesting hearing you say that, and I've heard you many times, but when you really just kind of take a seat back for a second, that there's a lot of other bigger things to consider other than just what you just said. Who's doing it? Even if you did take a great course, right? You have
Right.
the credentials to do it. Other stuff is going to happen. I want to tell a super quick story, because many of you have listened to me. I think this is my 105th episode, 10 years. But it's funny that you said you've been with Quad A since 2009. So I was with Medicis. People know that's Galderma now at 2007. I went to Zeltique. Long story short, I started Terri Ross Consulting in like 2011. But I got to be a managing partner, right, with 3 surgeons in a derm in Beverly Hills. So I was an owner of a med spa. And we got busted. We got busted the first year. And you can imagine, I went to go sit with Alex at Am Spa. I was with Berta doing everything, right, by the cuff. But this is when it was all starting, the big hype. I didn't know you then. And and I'm sure you can shed some light, and I'm sure everybody has a story to tell, but I'm sharing it with you guys from the level of seriousness. For one, I was scared to death. And 2, it was a couple that walked in. I didn't know how this was all playing out. They walked in wanting Botox. And one of our providers had passed, like literally she passed her boards. It was all legit, or it was nothing shady and crazy. But she had like NP on her coat, on her lab coat, but she had not received like the physical like degree in the mail. And it was a whole big situation. Anyway, I just share that to let you know that like I've kind of been through some of this stuff. And so I think it's also very humbling and prideful that the things we do at Terri Ross Consulting and what we teach is very serious around this. One, because I had to personally go through it. And, shit went down the way it went down, and I'll kind of leave it at that. But kind of as we continue this, and to your point, Tom, if any of you are listening and there's any sort of gray area, we're going to get to Tom's contact at the end. But, Tom, continuing on this medical and legal risk landscape, from a regulatory perspective, what are the most pressing risks providers and patients currently face, right, in this medical aesthetics environment? And when we think about what you said, that people need to really embrace this accreditation as something super positive, right? Like you said, the good ones that are doing the right thing, the right care, the right safety, the right results, the right intention. But how will going through this accreditation process for them help mitigate any of the possible risks?
Yeah, so there's a few things there, right? So as you said, you shared a really good anecdote there about sort of like buttoning something up, right? Like you guys were doing everything right, and it's a mailing issue, it's a dating issue, right?
Yeah.
And here's the thing, and again, to go back to listeners, right? There's however many people are going to listen to this, and they've got some story in their history that they don't really like to tell, because they think it makes them look, I didn't know what I was doing. I did something wrong. I did something bad. I don't want people to think less of me. And the truth of the matter is, I haven't met anybody in medicine, broadly speaking, all of medicine. I haven't met anybody in medicine that doesn't have sort of a horror story near miss like that, right? So we can all use a self-check, right? We can all use a sounding board. And I think that's it, right? First of all, our shared knowledge kind of makes us better. Right. That's right. We're all wiser than any one of us is. And so when you talk about credentialing, our credential wasn't buttoned up, right? Because that's exactly what happened in your case, right? Our credential wasn't buttoned up. Not to give another spoiler alert, but whenever we run our top 10 deficiencies, documentation is always up there as well, because it's stuff that gets lost, right? It's stuff that it falls through the cracks. In terms of what the current regulatory risk is right now, it's kind of a mishmash, right? First of all, we live in the glorious United States, which means we get to deal with 50 different regulators. So whether if you're listening in Florida, Connecticut, Idaho, we may be talking about very different things, right? The second part of that is most of the states are just grappling with this now. I mean, a lot of our states are still grappling with surgery, let alone med spa and non-surgical aesthetics. But from my perspective, from the canvassing we've done and we've seen, obviously AmSpa has a pretty comprehensive list and they're pretty active as well. We don't lobby. We're not an advocacy group, so we're a little bit less familiar because honestly, we look at the science and we look at what we really think is important for safety, and then we push that forward. And if the states want to get on board, then great, we got to train for them. But if they think that they want to look at something really specific, we'll look at it and see, well, do we think it's important enough to kind of absorb into our hive mind, or is it something that we'll look at just because the state asked us to? Having said all that, my experience is mostly the states are looking at the person, right? When I talked about the 5 Ps that our group talked about, it's really they're trying to get a handle on who is holding the syringe, who's doing the injectable, that's really their first focus. And I don't blame them. I think that's really the logical first step. What I think is interesting is that more often than not, legislation and regulation comes from a complete disaster. I mean, anybody who's been around long enough in medicine probably remembers in like 2009, 2010 again, there was a facility in Nevada that used basically, that was like re-infiltrating saline bag to flush lines and expose hundreds of patients to like Hep B, Hep C, and HIV, right? And that started a huge national push toward infection prevention, and Medicare got really laser focused on infection prevention, and rightfully so. But it's reactive. It's always reactive. And so you had the people in Arizona with the vampire facials that had some exposures and things like that. At some point, some state is going to have a big enough problem. And we know some that are kind of bubbling up right now. I think Texas has one going on right now still. And then the state's going to come in and say, no one can do it, or no one can do it unless they're an MD or an NP, or they're going to come in heavy on the practitioner. Where they may go, where it might be logical to go, is to the facility, as we talked about, as we do. If you look at the surgical world, like the Department of Health looks at facilities, hospitals, ambulatory surgery centers, big facilities. In most states, the medical board is really who's evaluating or regulating office surgery, because really they're talking about the practitioner's license. So even though they're looking at the facility, they're still boiling it back down to the practitioner's license. And I think that's the logical trajectory for the states with med spas, right? They're going to say who can inject. And frankly, if private industry, kind of the way the plastic surgeons did it, if there's not a movement to get ahead of the states, then what's going to happen is, somebody somewhere is going to make a mistake, and that person, whatever credential they hold, the legislature is going to decide, well, that credential is the one that's not good enough. And it's the people just above that credential who should be providing this service. And they may then turn around and look at the facility and the product and make sure you're ordering not from Alibaba, and make sure that you have a good sterile supply room. But it's still ultimately going to come back to the person involved. I don't think that they're going to go the facility route. And, the states are very different on that. Some states have financial penalties. Some states just kind of say it without monitoring or an enforcement arm. I know in Florida, with med spas, there's a medical directorship requirements in terms of how many facilities any one person can oversee, and how far they can be away from their primary residence or place of business. So I think that's what you're seeing right now. I don't think it's very clear. It's kind of like trying to grab smoke. They don't really know how to handle it yet. So there's a lot of ideas bubbling up in diverse places, and I think they're kind of waiting. Now you mentioned the segment on med spas, and just after that segment, I had the opportunity to speak to 3 of the most prominent and active states in terms of regulating location of care. And they all kind of said, I can't say who, but you can probably piece them together. They all kind of said, not yet, but soon. Like, this isn't something we're ready to tackle yet, but soon.
So I have a million questions, and my questions are stemming from now consulting, God, almost 20 years. We've done around 150 like new medical aesthetic practices. How, and I'm constantly reaching out to you or again, law firms to make
Yeah.
sure that like the structure and the compliance and the medical directorship. But how is it? And I am baffled about it. And people know my style and they know that I'm pretty bold and I'm pretty bullish in my responses sometimes just because I've seen everything under the sun, the good, the bad, the ugly. And the ugly is ugly, guys. It's ugly. And um how and I get it, right? This world we live in here and 50 different laws and states and but how can medical directors be, and with all due respect, your internal medicine person down the street? Like how can that happen when then you're saying, then what I hear you saying, if I'm hearing you right, that it's down to the person and then they're a person with no experience in the space.
Yeah, it's interesting that you asked that question because we sometimes get a similar question in the surgery world, and that's the best way I can analogize it. But I don't want to keep going back to surgery just because that's our home.
Yeah,
But
yeah.
I do think it's
But
important because we have facilities where the medical director of a facility is perhaps a GP, is perhaps a general surgeon. They're not performing cases there, right, at the center, depending on the specialty, right? We have pretty strict scope of specialty training and scope of training kind of scope of practice rules, which kind of keep us making sure that people are providing only the services that are within their principal AMA core principle 7 that you only stick to within your specialty. So we want to make sure plastic surgeons are doing plastic surgery, that orthopedists are doing orthopedic surgery, that urologists are doing urology, et cetera, et cetera. And so sometimes you do find that we have like a general practitioner or a general surgeon as the medical director. And at least as I've heard it kind of worked through our system and worked through the clinicians, the people who are in the know, because, you mentioned my academic background and what's, conspicuously missing is medical training. I am not clinical in any way. But when I've heard this problem work through, the real question is, from a medical director standpoint, they want somebody who can understand the system, the body systems, right? And the full medical background and the full medical implications for the patient. And so in many cases, you can have somebody who's another trained medical professional because they should have still the underlying, especially a physician, you should have the underlying understanding of the entire human body and all of the systems, so that you can help guide, you can direct sort of the normal course of care, you can help sort of discuss and plan for adverse events and emergencies, and then respond to them, right? Like the key, right, is not to have, say, an ophthalmologist who's working on an eye, and then they understand what's going to happen with an adverse event. Now, we've had questions about podiatry and about nurse practitioners in some states where they're allowed to be kind of independent. But our board, and I think very, very similar, a lot of the states say, well, you can be a medical director and not provide that specific service because you have the underlying medical knowledge to help plan and to help recover a patient. So at least that's the rationale I've heard used, and it makes some sense to me. I mean, in some cases, right, if you have an ophthalmologist and the patient has a cardiac arrest, is another ophthalmologist as a medical director really going to be the best thing? So to that respect, I think I can understand it.
Yeah, and look, there's going to be different, strokes for different folks and different stories. And I guess some of the stories I have heard, and I'm also asking, maybe this is a bit self-serving for me as a consulting firm, that we want to guide them in the right way, and people want to start. And I applaud anybody who has a desire, to get into the space if you're doing it for all the right reasons. I love it, and there's room for everyone. But then the matter comes down to, well, how do we find a medical director? And someone told me the other day, I mean, the shit I hear, it was some random, hire somebody on the internet kind of thing.
Put on
I was
LinkedIn.
like, yeah, I was like, hell no, absolutely not. Or, you get shit like your necrosis of the nose. And, I understand. And again, with all due respect to a GP and internal medicine, whatever
Yeah.
therapy and specialty you have, that you are clearly an expertise in some level of degree of medicine. But then how are you going to take care of like a necrotic nose,
Sure.
or a blind person getting shot with Botox? I don't know. Like,
Yeah.
it's a struggle for me too. And it's not even, hell, I'm like not a clinical person either, but just wanting to do the, I don't know,
Well, no,
guide people in the right way and not
you
have
make a
my
good point.
biased opinions.
You make a good point. I think part of it, right, is about the level of involvement. That's why you really do need, and any rational medical director is going to need involvement, right? They're going to need to become familiar with the services. They're going to need to become familiar with with the likely adverse events, right? And they're going to have to kind of read up on it, right? I'm a lawyer. I've done all kinds of training, and I primarily did M&A. That doesn't make me knowledgeable in estate planning. And if I took on somebody's role in estate planning without doing the proper research and educating myself, I mean, we have a duty of education. If I started planning someone's estate and something went haywire, I still committed malpractice, right? And I think that's really the key, right? You have this duty as a medical director and as the clinic who's hiring the medical director to make sure there is involvement. You want to be planting a tree, not just cultivating a weed, right? So the roots need to go out and spread throughout the organization. And I think that's critical. And to your point, when you ask kind of about the regulatory and legislative landscape, I'll go to Florida because I suspect that this is going to come up at some point in Florida. In Florida, if you're in a surgery center that is not accredited, it used to be that the medical director faced some serious penalties. I think it was financial penalties per day that you were operating. And I think certainly license risks. And there might have been some real criminal penalties involved there. That wasn't good enough because everybody can find somebody somewhere who's willing to roll their dice with the license. What they did then was expand it to every day that clinic is operating that is not accredited. Every single physician on staff is subject to financial penalties, their license, and possible criminal penalties. So I think that's the type of action you're going to see if people keep throwing ads up on LinkedIn and hiring a medical director that's 6 states away.
Oh my God, crazy. God, such good stuff. Let's talk about the core pillars of like what this new accreditation might look like and why is it going to be meaningful for patients and providers?
Well, so, you started out with a couple of anecdotes or, you've peppered them through here. And I think it's good to go back to it, right? Because the first thing is this is a commodity, right? And I tell this, it's an appropriate analog that I tell to plastic surgeons because we did the research. So in 2021, 2022, we wanted to really understand better patient sentiment, patient decision making. And so we started digging into patients and we started digging into them in a lot of different specialties and service lines across all demographics, racial, ethnic, language, all kinds of areas, right? We really try to break it down. And what we found is patients want someone with expertise and they want someone with experience. Yet, if you push them on that a little bit. Now, we didn't do this ourselves. We brought like outside firms. It was all blind. They had no idea what the research was. It was all scientifically on the up and up. But if we push them on those concepts, patients cannot articulate what experience or expertise means, right? And what the real terrifying thing here is that I don't want to flip this the wrong way. I think it's 29% of patients, the minute they see MD at the back of someone's name, stop doing research, right? So this is what doctors, they think as soon as I see MD, well, they wouldn't do it if they don't know how, and they wouldn't do it if they didn't have a lot of experience doing it. And this is with doctors, which are like, if you go back 30 years, I think Gallup does this poll. If you go back 30 years, physicians are always in the top 3 most trusted professions. It's always like nurses, physicians, and pharmacists in some order, right? So this is the most trusted profession across the board in the US and really worldwide. And so as soon as they see MD, people just go, oh, they must know what they're doing, right? And so I think it's the same thing here. If you're offering it, people make this assumption you know what you're doing, that you're safe. And so I think that commodity that comes from that is, well, all these places are doing it. Someone would have stopped them if they don't know what they're doing. So we're going to just trust it. And so if I walk in and say, Terri, are you going to do the services I want for $500? If you say, sorry, that's too cheap, they're going to vote with their wallet. And that's the scary part. That's the pressure that comes up. So I recognize that. And I think it's important, but I also think it's important that patients don't see this as risky. And even in that meeting that I told you about from the American Association of Dental Boards, one of the presenters there who's supposed to run this really comprehensive class and this really comprehensive training seminar essentially went through really interesting, really well-founded stuff and then said, but you can't really hurt anybody with this stuff anyway. You can't really do any real damage. You can't do anything permanently, which forced me then to get up in this room and say, sorry, everybody.
Wait a minute.
But everything that this person said of value for the last 30 minutes is now completely off. I find no value in it because that is not true. You can have permanent blindness. You can have necrosis.
Yes.
We've had patient deaths from different types of services.
Yes. Yeah.
There's a lot of stuff that can go wrong for real and for a long time. And so I think, I think that's really where we need to start from. We need to start from the core tenet being patient education, transparency, getting patients to advocate for themselves, not in the way that they're just walking in and waving some cash saying, who's going to do what I want for what I want, but to say, I need to make smart decisions for myself. I need to treat this like healthcare and find the people who are intentional and meaningful and serious about these services. When we go beyond that, the core tenets of this program are very similar to what they would be in other medical programs. And I think that's the key, right? We're bringing this back to medicine, right? Are the products not just valid? Are they not expired? Do you have a control system to get rid of things that are expired? Are they properly maintained? Some of these things are temperature controlled. What's your cold chain? What's your monitoring? All that type of stuff, your protocols. If I was going to break it down into some really simple places, right? We're talking about the training of the professional. Yep. We're talking about the documentation of the organization and the team, their personnel record, protocols, mission statements, things like that, right? Intentional leadership. We're talking about the medical documentation of the patients. We're talking about the physical environment of the facility. That's almost the easiest one, right? You can invest some money, you hire a really good architect, you got a great space. That's almost the easy one. Right. The surfaces, the equipment, like the kind of more permanent equipment, the supplies, how they're handled, processes and protocols. So in the facility, how you turn over a room, how you turn over, the patient experience, right? And then again, just when you got kind of circle back around to record keeping, there's also sort of the ad hoc record keeping, right? Like emergency planning and preparedness, infection prevention, meetings, things like that really fall by the wayside in a smaller organization. You want to inject, we really try to limit the bureaucracy, right? We really try to stay focused on what's going to be at the point of care. But there is some paperwork that really tells the story of what you're doing and are you living it daily, right? We try not to go overboard with the checklist, but there are checklists that are helpful, right? Like you wouldn't get on a plane if the pilot didn't do their walk around and check off their checklist. Right. Why would you let someone stick a needle in your face if they haven't done the same? So the point there is, are we having our meetings? Are we having our quality? Do we have a quality assurance program? Sure. Things like that, right? Now, I'm not going deep into it like we do in surgery, but we're talking about concepts. And the big concepts are documents and record keeping processes, making sure that if you've got 12 staff members, that the same thing is getting done every day, no matter who's on staff, right? Because that variability equals danger. Those are gaps. Those are risks. And so that's really the tenets that we're looking for. Is the equipment good? Is the supplies good? Is the facility good? Are the people good? And is it documented, right? It's really logical. It's really logical, but most of us don't have the time to sit down and be our own sounding board.
Yeah. Well, my God, I was writing all of I think I wrote down 12 or 13 points that you just made that sadly, and I think this is one of the reasons, we started 4S with Isaac and Dr. Schultz, our own sort of MBA of aesthetics, because while there's phenomenal societies, there's not enough on the business, right? On the credence of the business of aesthetics. Sure. And this is part of it. And it's also scary when people don't know where to go, which we'll kind of get into later. Like, who do you hire other than you guys, Quad A and this new accreditation? But like, who does this, right? And now for the accreditation piece, it will be you. And so let's just continue on the path, because now we're talking about, which is, again, I'm so honored, I'm so humbled to have been a part of this with you and some really amazing key opinion leaders on this task force. But it's been a bitch. Let's call it what it is, right? Let's call it what it is. Our opinions and controversy and all of the things that we all had to come together to develop. How has it been designing this global accreditation framework? Again, in such a diverse, rapidly evolving field where we're trying to take into consideration I'll let you talk about it. Well, let's talk about it. What have we had to take into consideration? Because I want people to really hear the value of what this task force, it's not some just people got together with nothing better to do right at a, Sunday night to talk about some shit. Like, it's been a lot of really diligence, especially on your part, and a lot of hard work with a lot of knowledge behind a lot of people, and to do the right thing.
Well, yeah, I think it's definitely not a lot of people with nothing better to do. I think the old adage is, if you want something done, give it to a busy person,
Yep.
right? If you and typically what my experience is that the folks who have the most to do are the ones who never say no, so they show up and they keep
Yes,
showing up. Yeah, so I mean, the working group really came together right around May of last year. And again, this sort of had been bubbling under the surface for a while and kind of building momentum, and then it galvanized rather quickly. And so it was a bitch, and it always is a bit of a bitch. But thankfully we've been through it like 11 times doing different programs. So it's a little bit of a known demon. But the reality is, you've got to get the right people. You've got to get the right voices in the room, because you can very easily go off the deep end. And I think that is really the fear whenever we bring this project up to anybody in the med spa space, is, especially if they know our background, is, oh gosh, the plastic surgeons are going to throw a wet blanket on it and they're going to try to rein it into under their control. And that's really not the case. I won't name names because I don't know who wants to be associated with the work or not, but I didn't ask for permission. But we started out with a group, and I think it was 4 plastic surgeons, as among other people, but 4 plastic surgeons. And then we had, yourself and a couple other folks on the consulting side, a bunch of nurses, some folks that worked in kind of the other as injectors. And then what I think was most laudable and most commendable by the working group was to bring in subject matter experts that worked specifically in women's health, infusion services, men's health, because, the med spa space isn't just about cosmetics and aesthetics. It becomes some of these other infusions and things like that are becoming more popular and more prominent, and that every center has a different mix of services they're providing. So not only are you trying to get everyone's minds on the same page, but you're also trying to accommodate widely varying service lines. But the plastic surgeons, to their credit, came in originally thinking, well, we need core 4 physicians to be running these facilities, and then realized, well, there's a way to do this differently. There's a way to do this without kind of strangling it and going over the top. And to their credit, they started to reach out and ask yourself and ask some of the other consultants, can you bring us someone? Can you bring us a gynecologist that does a lot of the sort of female rejuvenation and things like that? We all learned new terms. I had never heard the term scrotox before. So
you might want to go try it too.
That was new to me. I'd never heard of it. So, we all learn, we continue to learn. But the thing that's great is to see that group grow and take different approaches and come off of maybe preconceived notions, and to decide, okay, what is practical? What is rigorous? What is best practice? And then what can we support with data, right? Because we're always asking that question. If we compromise here, does that compromise safety? How does the data support that? And so we had 2 nurses on our team that kind of ran the staff liaison part and brought everything back. And so that was, most of the summer last year and into the fall to even just get a really strong draft together. And then, that gets dropped on the desk of our formal standards committee, which is run by medical professionals who dutifully said, this is not my area of expertise. We know that outsiders and we know that people from the industry worked on it. I would like a completely new set of industry experts, non-physicians, operators, injectors, people who run these facilities to weigh in on this and tell us what big areas we might have missed that we can go and research further. And so we're actually in the process of doing that sort of second level independent review, kind of peer reviewing right now. So that process is incredibly rigorous. And what I'll tell you is once they give feedback, we're not done. We're setting up pilots right now to pilot inspect a certain number of facilities with some people who are from the community who would be the inspectors. This whole thing is set up to be peer based. So, we send surgeons and anesthesiologists into surgery centers. We send therapists into therapy facilities. We're going to be sending injectors into med spas and non-surgical aesthetics places. And so those folks will be doing some pilots. Once we get feedback from that, then we'll be publishing for public comment the standards so that there can be more people weighing in on it. That again will have to be validated by the data. But all of those checks and balances are to go back to that thing that we said before, is that the knowledge of the community is stronger than any one person in the community. And we want to make sure this threads the needle of rigorous and reasonable. I mean, if we come up with something that says, well, only plastic surgeons can run med spas and only they can do certain procedures or most of the procedures, that's just not going to be practical, and it won't be adopted by anybody. And then conversely, if we say, well, yeah, the bridge people can do injections, then we're not doing any good for the patients. So it's really about targeting and making sure we're hitting the sort of right in the bullseye.
God. So how do you think this is, well, one, my God, I have two questions. When do you think that we could foresee, if you even had a guess, of when this could come together and be like legally rolled out? That's my first question. And my second would be, how is this, and maybe it's the reverse. How is this going to change the landscape, right, of the med spas, whether it's even today or in the future?
Yeah, I think so first question, I think later this year you'll see published standards. I'm hoping these always take a lot longer because there's so many busy professionals involved. This effort always takes longer than I expected to. I think later this month we'll be listening to that second group of people weighing in. And I think from there it goes to the pilots and publishing for public comment. So I think later this year we'll have the application available, and we'll be building out so that folks who want to become accredited can download the standards. It's an open book test. I tell that to everybody. Okay. No surprise. You'll have the same text that our surveyor has. So you could download the standards, start preparing for it. It takes a while to prepare because you got to document right, organize right. Yeah. So I think later this year you'll see that. Consultants like you, like others, are incredibly valuable at helping facilities prepare. It can be overwhelming. So that sort of time frame, our data tells us that most facilities take somewhere around 5 months. In the surgery side, I anticipate it's going to be shorter here, but that's the only data I have. So I think later in the year you'll be able to start downloading that stuff and preparing. And I think by the new year, right around the new year, we'll be ready to start doing official inspections and official surveys. We like to say survey, not inspection. Yeah, sounds a little bit less punitive.
Sounds a little bit better, right? Exactly.
less punitive. So I tentatively say that, knowing that things always move slower than I want them to. But I'll bear the lashes if I got that wrong. How it's going to change the landscape, I think, is potentially twofold. First off, I think some eager states who are struggling with how to do this are going to say, got it. We already had a turnkey solution. We've done this in surgery. Let's do that again. And it's going to be a lot less painful, but it's going to run out the bad actors. If you get a state like New York that's really good on the surgery side, they have an office surgery accreditation mandate. They monitor for it, and they have a really fast and kind of severe enforcement mechanism. It forces out bad actors pretty quickly. Yeah. I think that's kind of lesson number one. Lesson number two, I think, is going to happen is that other areas are going to move a lot slower because that's kind of their political philosophy, their natural tendencies to kind of say, well, we're not going to overregulate. And so what's going to happen is the cream of the crop, the early adopters, the eager, the folks who want to market based on safety and building patient confidence and all that stuff are going to adopt. And hopefully they hit a critical mass to where the folks who are doing things the wrong way are conspicuous by their absence. Because I think there is no, you talked about the marketing techniques and tools and stuff like that. There is nothing more ethical than marketing on confidence like that. And saying, look, you don't know how to ask these questions, but Quad A does. And they just put us through a survey where they asked us 350 questions. And by the time we got that certificate on the wall, we had to be able to say yes to all of them, and they checked it, right? That's a really big thing. And if I go back to that study from 2021, 2022, 58% of patients that were unwilling to look at outpatient care because they were skeptical of it, if they were provided what they called the right kind of information, which was that kind of information, they were willing, like 35% of them were willing to flip and become open to the idea of outpatient care. So I think the same dynamics will play out in med spas. I can't speak to it with data because we just don't have it yet. But that research really powerfully said, essentially 80% of patients' trust in the facility went through the roof. It was like 43% became much more trustworthy, and whatever the other 29 or 39% became more trustworthy rather than much more. And it was like more trustworthy, more confident. They felt the care was more compassionate. They had more confidence in the team, and it was about the whole team. So if those dynamics play out, you're talking about 80% of your potential patient population having an improved view of your facility, of your service line, and by a factor of sometimes of as much as 20%. Like if any marketing firm said, we can improve the average consumer's perception of you by 20%, you dive on it. Yeah. So I think those are the things that are going to play out in the non-regulated states. And then unfortunately, if some, horrible adverse event happens, then they will quickly flip from non-regulated states to regulated states. And that'll be slow dominoes.
Of course. That was really empowering, just what you said, this last statement. Even for me to just sit with it for a second, because we both said it a couple times during the course of this podcast, which is that if the industry is a commodity and everybody's fighting for marketing terms, right? We're fighting for the Botox and the Restylane and the Halo or whatever the hell you're doing, boob jobs and breast dogs and facelifts. And it's all the same shit. It is all the same stuff. And then it's who's got more money. It's pay to play. And I mean, it was empowering to hear you say it, but empowering for me as a consultant to sit here to say how prideful, right? How humbled, how honored, right? How legitimate would you actually be when, again, to your point, you can say this with like not even a blink of an eye, that like you are the best of the best.
To your point about like, sort of the MBA in the 4S Summit, like that sort of MBA for these practitioners, right? You can choose to compete on one of two fronts, by cost or differentiation. Well, if we all just go on cost, it's going to be a race to the bottom. We're just all going to start cutting costs, cutting corners, cutting people, and doing it, as cheaply and quickly as we can, turning it into a factory, and that's going to increase the risk, right? Or we could differentiate. And how do we differentiate? Well, we could be Volvo, and we could be the safest car on the road, right? We could be Mercedes, we could be luxury, we could be Ferrari, we could be fast and passionate and exotic, right? We have to choose, right?
I love it.
And you could choose this thing, but the thing you shouldn't choose is to be the cheapest, easiest, fly-by-night. You don't, nothing wrong with it, but you don't necessarily want to be Kia or Hyundai, right? Like you want to be Mercedes.
Listen, so you guys need to go check out my post. I talk about this book all the time, but it's a picture of me posted today. And the book is called Someone Needs to Be the Most Expensive. Why Not Let It Be You? And everybody should read the damn book. It's very life-changing. So kind of as we wrap up,
you didn't even pay me to say that. You didn't even set that one up. That was completely...
I know. And even the analogies you use, I use it. So I love it so much. This has been such a powerful segment, Tom. Thank you so much. So, kind of as we come to an end and think about it from the role of the patient's perspective, right? And them driving demand. for kind of what you've just been talking about in this last topic. How can the industry better educate? Because I think that's one thing. And you just gave some statistics that I did not know, by the way. I mean, that percentage of patients not knowing what experience or expertise means. And I get it. What would it mean when they don't know what you have to do to go get trained to inject tear troughs, right? They don't know the difference between an ocular plastic and a general. Like, they just fundamentally don't know some of these things. So how can then we, and whether it's now or later, and I'd like to talk about now, how do we better educate the consumers on the safety and the quality of these non-surgical med spas?
Uh, that's the challenge. And I do have a talk on it. Maybe I'll come give it at the 4S
Yes,
about
please do.
yeah. As much as I'm not like a social media person, I get it and I understand it. Not that I'm not a social media person. I'm not super active on social media, much to our marketing team's chagrin. But I get the need and I understand the dynamics and I understand areas of it. And so we have a talk a little bit about the ethical use of social media. The real challenge, of course, right, is especially in the aesthetics, right? Aesthetics world is by definition a world of attraction. It's what's sexy, what's attractive, what can I draw you in with? So we have to find a way to make safety sexy, right? And so whether it's taglines like that, whether it's I just came up with that one. No one.
I love it. That was legit. I love it.
But we have to make safety sexy, and the point is, like, how do you catch attention on Reels and on Instagram and on social media and on TikTok? How do you speak to that, right? And one of the things that I talked about, I gave a talk last year about ethical use of social media. And it's way more wild, and especially in some of these other markets. If you have listeners from other countries, there's a lot of countries that have advertising bans, like where you can't advertise on.
Yeah.
Sure as you can bet, people are talking about it on TikTok and they're advertising without advertising, right? But again, I'm a lawyer, right? So like, I'm not gonna, if I was still practicing, I wouldn't want to like dive down into the muck and start covering, really salacious stories. But what shows up on my feed a lot is these really good lawyers who capitalize on the really salacious story. And then they pop in over the top, and then they really give you a nice, analytical, thoughtful breakdown of what just happened. So I'm sort of reminded of like the Johnny Depp Amber Heard case, right? Like it was all over social media. I'm not going to watch that. My wife glued to it, right? But I'm not going to watch that stuff. But it's still going to pop up on the reel. And then this lawyer pops in and says, okay, this is a really interesting point about evidence. And then he's talking about really educating about evidence to a way that's engaging to me. But they use the sexy hook to get you in and then to educate you. I think we need to do more of that as a group. And I think we need to talk to patients. The industry, medicine as a whole, does a great job of talking to each other about how good somebody is or some program is or how knowledgeable that person is. It's really hard to do that to patients. And frankly, a lot of patients don't really want to listen until it's time to listen. And then it's kind of too late. But like, that's the thing. I think we need to have much more forward-facing conversations with patients. We need to start speaking about safety from the get-go and in a way that's validated. Like that's the one good thing about accreditation, right? It's the other guy can't fake it. If they didn't do it, they can't fake it, right? They can say, "Oh, I trained with the best." What does that mean? It's nonsensical.
Right.
But they can't fake earning that credential and earning that thing and having someone walk through the office and check all those boxes. So talk about it. Talk about, we got inspected. We put ourselves through a rigorous process to make sure that when I show up for you today, I'm in the best spot to treat you safely so you leave here with the result you want and not an adverse event.
Yeah.
I think that's powerful stuff to be explicit. I think we rely on it being implied because we don't want to talk about it, but I think there's a power to being explicit a lot of times.
Is there God, this is amazing. And maybe this is a silly question, but back to your point about talking to the patients, which we don't.
Yeah.
How and I also can say this too from my perspective because I do again, our company has the pleasure of working with over almost 20 years, right, of helping, whether it's a startup or everybody that, people that want to scale and now they want to consolidate and now we're prepping them to get ready to sell or just to grow and to train the team. Is there anything that the practices listening today could do, because I think that is such a misunderstanding. People, like we're talking about, people don't know the difference between a plastic, an ocular, a general, a facial, an
Yeah.
NP, a PA, an RN, an ST, and then STs in certain states can do these medical things, and in California where I live, they can't do shit, but they do. Like it's bananas, right? Like it's bananas. And so like people might not like what I have to say sometimes, but I'll be like, look, I'm not a lawyer, but if you work with me, I'm here to protect you of who can
Yeah.
do what.
Yeah.
So is there anything that people could do now? Hold any cohorts or educate? I don't even know. Is that a thing?
I think people are still, I think we're all still struggling with that conversation and figuring it out, right? Because I think medicine as a whole, I don't think it's specific to this industry. Medicine as a whole has been woefully inadequate at talking to patients because think about like our parents'
Yeah.
generation, it was just whatever the doctor said, you're going to do,
Yeah.
right?
Right.
But
Right.
medicine wasn't
Right.
commoditized to that degree, right? And
Right.
it wasn't as much of a business as it is now. So we need to speak in a different language than it was back in the 50s and 60s. So I think that we need to, uh, I think there's probably some experimentation that needs to go on. I think there's a lot of transparency that needs to go on. I'll draw a different analogy outside of medicine. I had done a consulting project many, many years ago for a big like oil change, quick lube type place, right? And it turns out that they are more accurate. Their accuracy rate is higher than like McDonald's drive-through, right? They're incredibly accurate. They don't make mistakes. It was really astronomical, the number, the ratio. But if people are following their maintenance schedule, they're getting a oil change every 3 months. So they every time their car has a problem, they just had an oil change, right? It was within the last 3 months. So they say they messed up my car, right?
Right.
So
Right.
so these folks were really, really accurate, really reliable, but they were always getting blamed. And one of the biggest problems was there's a huge knowledge asymmetry. The normal consumer knows nothing about cars. And if they know something about cars, they're changing their own oil. So the
Right.
normal consumer
Yeah. Yeah.
who's going into a quick lube place knows nothing about cars. And so when they're sitting there, they have nothing going on, no synapses are firing, and then they leave and something goes wrong and they think, well, they did it, right?
Yeah. They did it.
So it
Yeah.
was all about investment in transparency, literal transparency for them, right? They were like, if you put a window in the waiting room where they could see us working on the car, trust increases dramatically, right? So I think what we're talking about here is we need to provide a level of transparency into what it takes to be a good practice, right? I am checking my staff for how well they're maintaining my sterile supplies. I tell this to everybody all the time. Probably the most determinative person, if you have an adverse event in your facility, is the person in charge of your sterile supply room, and like probably the least seen member of the team.
Right.
So,
Yeah.
right. So like we need to talk about that with patients. We need to talk about how I'm trained, how that person's trained, how that
Yes.
injector's
Yes.
trained, and how we do drills. Like we don't want to talk about those things
Yes.
because we don't want to talk about the bad times, right? It's like talking to your kid about like, hey, if a hurricane happens, we're going to do
Yeah.
this. And they're like, I don't want to talk about this at all.
Yeah.
I don't
Yeah.
even want to think about a hurricane. But I think we do
Right.
have to kind of say, we've taken proactive steps to limit the chances that these bad things happen to you. And we're going to be really upfront about it. Like, again, Quad, we're not in the business, we're a nonprofit. We're not in the business of selling like merch and swag and stuff like that. But one of the ways that we try to help the facilities do that is we have like banners and stuff that you hang in the office to talk about that, to talk about the protective steps that this process means in order to build that patient trust and patient confidence. We have like templates for the website so that we can start having that conversation. And it's all still kind of new. So it's interesting. And you bring up a really interesting point about selling and consolidation. Private equity, corporates, everybody who's going to take this on, think about your risk as a solo practitioner. Their risk is not just multiplied by the number of places they acquire. It starts growing exponentially. So for private equity, for consolidation, for companies that are buying in, whether or not you have protective measures in place, I think that's one of the biggest changes coming to the landscape. I was in an article for Bloomberg September-ish, August, I want to say, of last year. And I believe they talked about it in the article, but I can tell you that the journalist said, private equity is kind of clamoring for this because their risk profile is too big to invest this kind of money, right? If I'm buying up 10 places and I don't know what's under the covers, I may not make the deal. And I've talked to a few lawyers in M&A who said, I can see that coming down the way for the buyers.
Yeah, absolutely. God. Oh my God. Can we all just take a sigh for a second? This was very very robust, Tom. Thank you so much. And very much needed. I
I'm
learned.
sweating. It got me all worked up
No.
about this industry.
I know, no, I know. Well, look at we're on this journey together, and everybody. I do have a huge tribe and a huge following, and I'm so grateful and I'm so honored, and I love all y'all so much, and I hope that you found this really valuable. I hope you are sitting back going, hell yes, I've been waiting for something of this caliber, of this nature to happen. And your input, you guys, please don't be shy. I am active on social, and I will feed all this to Tom, but please DM me, reach out to me, text me. You guys all know how to find me, but more importantly, Tom, I don't want them to be blowing up your phone, but how, if people really do want to reach out to you directly, or Quad A as your organization, where can they contact you?
Yeah.
And yeah, what feedback can you give to
There's
them?
a couple of great things. So first, the website is quada.org, just www.quada.org. I would highly recommend going there, kind of exploring around. We're redesigning, as we all are always redesigning our websites. But at the same time, navigate towards some of the resources. Look for the newsletter. Our newsletter goes out every 2 weeks. You do not have to be accredited to get it. I say that because if you sign up now, you'll also see the call for public comment when we do publish the standards. You can go then, click on it, comment on whatever you read, whatever you like, whatever you don't like, whatever you think missed the mark. Please do that. It's incredibly helpful for us. It is peer learning for us as well. Use that. If you have questions, info@quada.org. That's info@quad.org. That's our kind of general mailbox to our admins. We also have a standards mailbox. So once standards come out, you can ask our nurses question. They do a lot of research. They work directly with our standards committee. It's standards@quada.org. Those are all the best ways. If you go to the website, you'll also find all of our socials. I believe it's X, LinkedIn, Instagram, and Facebook we're active on still. No TikTok at the moment. And so you'll find everything you want there. But I think the biggest things is the newsletter and the website. There's a resources page where alerts go out and all kinds of stuff. So kind of navigate around those. You'll also find right now it's getting redesigned as well. And it will come back with the accreditation of the med spas as well, is a directory of facilities as well. So as an accredited facility, people will be able to search for you too, based on being accredited. And that's sort of, again, that education of the patient and that validation and that explicit conversation about safety and quality.
Woohoo, this was amazing, God. And you guys, this will all be in the show notes, so don't need to write it all down. But Tom, CEO of Quad A, thank you, dear friend. Thank you so much for spending your evening with me and the tribe tonight. I thank you so much for what you're doing in the industry, what you're doing in the space. Thank you for allowing me to be part of this really amazing task force. I'm so honored, and thank you for sharing just this wealth of knowledge. This won't be the only time, guys, we'll be talking about this. I'm sure this will be a very robust, ongoing, frequent conversation as things progress with these rules and the accreditation process. So I appreciate y'all so much, and I can't wait to see you guys on the next episode of In Touch with Terri. Ciao, guys.
Thank you.